Good evening, everybody. So thank you also for filling in the survey. And I see that a lot of patients would hesitate, a lot of colleagues would hesitate to give chemotherapy for prostate cancer or also for platinum refractory urothelial cancer, but they are less reluctant to give the chemotherapy if it's in a curative setting, like in muscle invasive bladder cancer. And this will be a bit a topic of my talk, also to give some hints, some tips and tricks in which patients we really need to proceed with chemotherapy and in which patients we better withhold or even discontinue the therapy. So I will only focus on patients that are under active treatment with immunotherapeutics, active treatment with chemotherapy, or active targeted therapy. And is there evidence? No, there isn't. So everything we will discuss here is a bit expert-based, is not based on a real robust evidence. There are only two reports. One report from the WHO from China that said if you have cancer and an infection with COVID, you have an increased risk of fatality, and it was increased from 1.4 to 6.7%. But you also see that if you have a cardiovascular disease, it's even higher, 13%. And there were also correlations with hypertension, that's also 8%. Another report that was published in the Lancet Oncology examined 1,500 patients, and only 18 of these 1,500 had cancer. And this was not specified which type of cancer. It was not specified what was the history. Did they have the cancer with therapy 1 year before, 3 years before? But they only mentioned that there was a higher incidence of admission to the intensive care unit that had cancer in only a very small population that was reported. So what are the current recommendations on an international level for the general care of patients undergoing active therapy with immunotherapeutics or chemotherapy or presenting for targeted therapy at a daycare facility? Well, you have to inform very well these patients about the symptoms of the COVID infections. You have to inform them that if you have fever, shortness of breath, if you have muscle pain or sore throat, that your oncological team has to be aware of the symptoms. And they propose to introduce a prospective follow-up. So not having the patients coming back at 3 weeks or back at 4 weeks and ask how were your last 3 to 4 weeks, but that you can follow them from a distance in a prospective manner. And we have the tools in our institution. We use the Remicare tool. Also in other institutions they use it, that you install an app on the smartphone of the patient, and you ask the 4 symptoms, and if they have 2 out of the 4 symptoms positive, we as an oncological team get the alert, and we will actively contact the patient if there's suspicion of the infection, and if yes, he will definitely not come into our day facility care before being tested. So all our patients now are getting that tool, and they also get the traditional measurements of hygiene like everybody receives. But if they come to our day facility care, they have to come through one point of entry. The triage has to be before they are in the day facility care. We have to make to lower as much as possible the chance that a patient that is infected is coming into the room where the IV therapy is being given. So the triage station before they coming into the facility. When they admit to the hospital, there are also barriers like everywhere with the screens. They cannot enter, they cannot make physical contact with the secretary. We also redesigned a bit the places that they get the chemotherapy or the immunotherapeutics. So if you have 4 patients in a room, we make semi-private spaces, that there is enough distance and not they don't have contact during getting the chemotherapy or the immunotherapeutics. And for sure, all the extra activities like educational group session are cancelled and are all converted to virtual sessions that can be found online. But let's get into detail. If you have a patient with prostate cancer that's being treated with abiraterone, a well-known side effect of abiraterone is hypertension. And if you remember the second slide with the evidence, if you have hypertension, you even had a higher risk of fatality. In that report from China, it was 8.4%. And we all know that abiraterone is giving a high grade or hypertension. Is there any evidence that you have a higher increased risk of fatality receiving abiraterone? No, there isn't. We don't have the evidence, but you can only advise that you have to follow strict the measurements of blood tension control. And you can also do that by that prospective app on the smartphone. They can fill in the blood pressures, and you can give extra antihypertensive medication only by teleconsultation. I don't know if everybody is aware that even drugs like enzalutamide or abiraterone or apalutamide can also give lymphocytopenia. In the studies, it was reported 20 to 38%, and even up to 10% grade 3 to grade 4 lymphocytopenia. And we can all imagine if you have a low level of lymphocytes that your immunological resistance is lower. So we can presume that you're at an increased risk of fatality during a COVID infection. Now we, in a castrate refractory setting of prostate cancer, we use more and more PARP inhibition, especially in trials, but also there's a medical need open now with olaparib based on the PROfound study. And with these drugs that we give normally we have up to 12% with DNA alterations in castrate-resistant prostate cancer. So these patients should get a PARP inhibition. And PARP inhibition, especially niraparib, gives a lot of neutropenia. So we should be aware that they are at an increased risk of complications during a COVID infection. And for chemotherapy, everybody knows that it's immunosuppressive, docetaxel, cabazitaxel. It even gets febrile neutropenia. Patients are admitted with fever and low neutrophils. So from that chemotherapy, it's not a surprise that they are immunosuppressive, and we could presume that they are at increased risk also for complications. So what can we do with patients during targeted therapy, like abiraterone? We can maybe give bottles for 2 to 3 months, but preferably with blood measurements at the patient at home. So near that they don't have to make an extra contact to the clinic. So you can give 2 to 3 bottles for 3 months. You can follow up the complications by the smartphone app, especially for the hypertension, but also for the other side effects, and also for the lab tests. And we prefer, there are no straightforward head-to-head comparison between chemotherapy and target therapy, but here it's clearly on an expert basis in favor of the pills, and try to avoid chemotherapy in these settings. And if you do choose for chemotherapy, if we have a patient who already received 6 cycles of chemotherapy in a castrate-resistant setting, I would stop. I would not go to 8 or 9 or 10 cycles like sometimes is given. So if your patient had already cycles, just stop. And you can also very focus on the tolerance in the first 3 to 4 cycles. If they was already admitted with febrile neutropenia, maybe you should be very reluctant to continue the chemotherapy. And maybe you can normally for docetaxel or cabazitaxel, you do not give growth factor support immediately, but you could argue that you can get reimbursement here with extra comorbidity risks that you could give if it's really necessary to give chemotherapy growth factors to all the patients undergoing docetaxel or cabazitaxel. Kidney cancer is, to me, another story. There, we made a lot progress in the last years. It's not like in prostate cancer that you change dramatically the cure rate or the extension of life. Here we had, I just remind you to the Keynote 426 and Javelin 101 that clearly improved the overall survival in patients at 12 months. If you give a checkpoint inhibition together with therapy, the checkmate 214 combined checkpoint inhibition with CTLA4, and also we have there already 42 months of follow-up, had a clear improvement of patients alive at 42 months compared to the old standard of sunitinib. And also patients who had a complete remission remained in remission for up to 80%. So in these patients, you can, if you are in the first months by starting this therapy, you really don't want to stop this therapy that really improves the cure rates of these patients. But on the other hand, especially in the checkmate 214, up to 1/3 needed steroids. And we don't like to give steroids to patients infected with COVID-19. So it's an increased risk. We also know with targeted therapy, you have a higher grade of hypertension. And as I already mentioned, hypertension was also a risk factor for fatality. And with immunotherapeutics, we have to be aware of autoimmune pneumonitis. So someone who's coughing and has fever and is short of breath can also have a side effect of the immunotherapeutics. You can also have increased liver enzymes by autoimmune hepatitis, but that's also a sign of COVID infection, first sign. So it's not a clear-cut scenario, but here there's a clear benefit of continued therapy, but with an increased risk. So some tips and tricks you can use for these patients. Well, try to avoid steroids. If necessary for therapy, you can maybe argue that someone who needs steroids during checkpoint inhibition has already a good response, and maybe you can stop or discontinue the immunotherapeutics. You can take blood the day before at home of the patient and decide if he has to come to the hospital. Try to do the reevaluations with CT scans that mandatory by the INAMI or the RISIF every 4 months. You can maybe delay it by 6 to 8 months and argue on a clinical ground if you can continue with the therapy. There's clearly a difference between poor risk renal cell cancer that you sometimes lose in the first months and a good risk that you can definitely delay therapy. And you can also consider less frequent dosing intervals. You have immunotherapeutics that you can give every 3, but even it's upcoming every 6 weeks or every 2 or every 4 weeks. And if it's combined with targeted therapy, you can also argue to give more bottles at once, that he has to come less to the hospital. Then totally different setting, urothelial cancer, metastatic. Just to remind you, if your patient is presenting with metastatic urothelial cancer and he starts treatment with cisplatin and gemcitabine, only 50% of the patients is still alive after 40 months. If he is ineligible for cisplatin, only 50% is alive after 9 months. And if you are progressive progressing after platinum and you receive immunotherapeutics, then after 1 year, you only have up to 40% alive. So the prognosis has to be there very much taken into account if you want to continue here the therapy. Because you don't, there's a lot of progress in bladder cancer, but it did not for the moment dramatically change the outcome. So here, for every patient, you have to individualize the benefits for these patients with the harms you're doing extra immunosuppressive. So if you start a new therapy, maybe you can delay the therapy. If you give 6 cycles, maybe normally you can maybe give to 4 to 5 cycles. So every patient has to be considered to try to avoid to continue the chemotherapy. Another setting in muscle invasive bladder cancer, there you go for cure. It's a totally different concept. We know the old trials that you increased the overall survival by up to 3 years. And here you want to make the life expectancy equal to someone without cancer. You cannot say we will delay the neoadjuvant therapy, because then you also delay the cystectomy. Like Carol said, it's also correlated with the inverse outcome. You can say we skip the chemotherapy, but then you also alter the outcome. So here I really think you have to proceed your chemotherapy. And in the next slide, what I could propose that me personally opinion, like I said, there is no clear evidence. I would give cisplatin gemcitabine instead of MVAC. I would give with growth factor support. I will definitely do the blood test before the cycle. All these patients had to be admitted to the hospital for the cisplatin, and I really should test them for COVID-19. It's already the standard of care here now, 48 hours before. If they are negative, they get a go to be hospitalized for the elective chemotherapy. We should avoid as much as possible the steroids for anti-emetic use. I would not do the interval imaging, only at baseline and just before surgery. For me, all patients now, for muscle invasive bladder cancer, we know that the prognosis will improve a lot with the new compounds, with introducing also the immunotherapeutics. So for all my last patients, I think the last 20 patients we started, we all included them in a clinical trial with chemotherapy with or without immunotherapeutics, or with chemotherapy with or without immunotherapeutics, with or without some IDO inhibitor. And there are a lot of trials running for muscle invasive cis-eligible patients, but also for the cis-ineligible. And what do we have to do with these trials nowadays? Well, BMS, Bristol Myers Squibb, made it easy. They stopped recruitment for all trials, so we don't have to decide. We are not even able to continue this trial. But there's a lot of other trials that are still continuing, like the Keynote 866. That's a very popular trial in Belgium from Merck. They continue. The patients cannot get the therapy at home. It's IV therapy, so they still have to come to the hospital. They recommend to continue all the necessary tests according to protocol. The only thing that changes is everything the patient can be done by phone. You can do it by phone. And the monitoring, we don't get the firms here anymore because they are not allowed anymore in the hospital. But I think this is a huge problem for these trials, and also for the outcome that we have to expect in some years. There will be a lot of protocol violations. We have to mention record all very closely, but for this kind of trials that will probably become the new standard of care in some years, I will definitely recommend to continue recruitment. But it's something for every trial you have to really ask you the question, is this a real benefit for the patient? And also for the clinical trials, I think the recruitment will be lowering a lot in the upcoming months. So you can find all the guidelines in my reference slide, maybe the last slide. I give you some references, maybe in the next slide. The ASCO, American Society of Clinical Oncology, has continuously updates for what to do with the patient during immunotherapy, what to do on your daycare facility. It's all written down there, but it's not based on a lot of evidence, but you can find clear guidelines how you can proceed. And also for clinical trials, you have the European guidance, but also the national guidance that give you clear guidance what to do with your clinical trials. So thank you very much. There's a lot of discussion who needs to be prevented for venous thromboembolism. There is, for outpatient treatment, we don't do it routinely. But to start now, so there's no clear evidence that we have to do it. You can do it on a case by case. If you have a lot of tumor, you can prevent for venous thromboembolism. But there's no guideline that you must do it. There are only guidelines when the patient is admitted to the hospital for an acute medical illness, that you have to treat your patient with preventive prophylaxis. I think with if the patient is in a state with hypercoagulability because of the COVID-19, that he will have a great chance for going to fatality. So I don't think we have to start right away with extra preventive measurements for that.
But would it change the choice of treatment? For instance, in a prostate cancer patient, would you would you change from docetaxel to an androgen receptor, a selective?
Definitely. I would avoid chemotherapy as much as possible during the diet. Yeah. Okay. I would give them androgen receptor. I will give them an abiraterone or an enzalutamide or an apalutamide, and I give them 4 boxes. I will ask them to do the blood measurements at home. I will try to every month you follow up with the prospective evaluation of his blood pressure and his side effects. You can easily do that. The tools are there. Just an app on the smartphone that you have a prospective alert to the oncological team when there is a problem. And you do just every month a teleconsultation. You look to the blood, you look to the side effects, and you give a go or a no to continue the treatment. And the re-evaluation by scans, you delay them, you make them longer, the intervals.
What about corticosteroids, which we associate with docetaxel, we associate with abiraterone, we associate with other chemotherapies, and sometimes we even change from prednisolone to DEXA, which is a highly potent corticosteroid. What about the safety of high dose or lower dose corticosteroids in times of COVID-19? Should we be very careful with that, or are we pretty safe by using them?
I think we should be very careful. There's a contraindication, meningitis. You even give it as a extra of the therapy, but here it's contraindicated to give steroids. So for docetaxel, we use it as an anti-allergic, not as an antiemetic. So the first thing I would say, try to avoid as much as possible the docetaxel. If you have already received 5 cycles, maybe you can stop. If you just started 2 cycles, it's another thing, but you can maybe reduce the dose of antiemetic because it's only for the allergy. You can closely look to what he does. If you give it for abiraterone, you give it for the mineralic corticoid excess. I think it's part of the therapy there. It's only 10 milligrams of prednisolone. Maybe you can go to 8, but I think you have to give him the steroids. But what I'm afraid of is if you have diarrhea during immunotherapeutics, for example, for kidney cancer, then you don't speak about 10 milligrams or you go to 64, you go to 80, and these patients I'm afraid of, then I think yeah, you definitely stop the immunotherapeutics, but you have to taper their 4 to 6 to 8 weeks. And I think these patients are at a very high risk if they are infected.